present about ovarian tumors in pediatric and adolescents, I thought about presenting about ovarian masses because not all what we are facing in pediatric and adolescents are tumors. And most of the things that we get in the real practice are things not tumors. So I thought to take it step by step. So my objectives will be that we'll discuss the fetal and neonatal ovarian masses, then we'll move to and how to manage them, then we'll move to childhood, then adolescent, then we'll talk about something I think it's very important these days. It's fertility preservation in pediatric and adolescent cares. And I think pediatric surgeons are the main people that have to discuss these things with parents and the patient in the beginning. So I thought to add this in the presentation. If you have any question, we'll take the questions at the end of the presentation. I'm happy to share the sources of my presentation also at the end. Okay. So let's start with fetal and neonatal ovarian mass. So if you were consulted about neonate or like neonate that have adnexial mass, you have to think it's benign until proven otherwise. So it's almost universally a functional cyst, only rarely will present at pathological, such as mature teratoma or cystadenoma. So if we talk about the incidence and etiology, we know that primordial follicles are present in the fetal ovary as early as 20 weeks of gestation age, and the peak will reach at 33 weeks. Ovaries are not quiescent during the antenatal or neonatal period, with there's a small physiological ovarian cyst diameter less than 1.4 centimeter, and those are benign. Sometimes it's up to 80% they are visible in antenatal ultrasound. The detection of clinically relevant ovarian cysts greater than 2 centimeters is less frequent. It's diagnosed 1 to 2 in every 625 neonates, yes. Among live-born females infants, incidence of clinically important ovarian cysts is estimated to be 1 in 2,500. So it's very rare and mostly benign. So what is the pathogenesis of fetal ovarian cyst? It's believed to be related to the follicular stimulation from placental chronic gonadotropins, HCG, or maternal estrogen, and fetal gonadotropins. So conditions that have excess placental HCG secretion enhance the formation of these cysts, like maternal diabetes, gestational hypertension, Rh isoimmunization, and those are associated with fetal ovarian cysts. Majority of fetal and neonatal ovarian cysts occur in the absence of other mentioned conditions. So if there is a neonate or even fetal, when we scan the mother and the fetal have ovarian cysts, we don't think about any associated fetal abnormalities. Rarely, fetal conditions like hypothyroidism, congenital adrenal hyperplasia, deficiency is associated with neonatal ovarian cysts, and it have been reported, but they are not that common. The bilateral, it occurs as bilateral. The range is very wide. It's only reported cases, so it's range from 1.4 to 27. So any range that you see, it's very high range. That means it is not that common. At birth, level of FSH, which is a follicle-stimulating hormone, rise rapidly due to the withdrawal of maternal estrogen and progesterone sources. This level peaks at 3 to 4 months of age, then gradually falls down. So if we have a cyst, it will be the peak is in the first 3 to 4 months. The regression of neonatal ovarian cyst over the same time period can be expected because will be rise in the hormones, then sudden withdrawal. So the diagnosis, it depends on the ultrasound. So if we have female 6, non-midline regular cystic structure, normal appearing of urinary tract infection, normal appearing of GI system, and no other associated anomalies, we think about benign ovarian cyst, physiological. So what are the characteristics in the ultrasound? We think about physiologic if it's simple, clear, less than 2 centimeters. We think about pathologic if it's complex, there is any symptom, solid component, echogenic walls, and if the cysts are big. So why we have more antenatal ovarian cysts reported? Because now the ultrasound is done every couple of weeks in the antenatal care. So it can be detected from 33 weeks, but as early as 19 weeks. So studies showed that histopathology assessment of almost 400 surgically managed fetal cysts comprised only 2.1 cystoadenomas and 1.5 teratomas. So the remainder are either follicular or thecal luteal cysts. So it's mainly benign. The most important thing is to know the differential diagnosis, to know how to manage. So any abdominal or pelvic cyst like mesenteric cyst, intestinal duplication or obstruction, hydronephrosis or mental cyst, lymphangioma, cortical cyst, all are differential diagnosis for neonatal or fetal cyst. If you see this ultrasound for female fetus at 34 weeks, the most important thing that we said that it is female sex, the urinary bladder and the stomach are intact. So we make sure that the urinary bladder, urinary system is okay, the GI system is okay. So this represents the ovarian cyst. So with the nature history, risk and complications, given that the function nature of the majority of cysts in infants, we said that with withdrawal of the hormones, the resolution is what we expected. That's why expected management is the main management here. Cyst complications like torsion, hemorrhage, they occur both in the antenatal and neonatal period. In the antenatal period, we will not know what happened because the baby inside the mother tummy. But in the postnatal, they can present with some symptoms that we have to aware of. Torsions, most concerning complications due to potential loss of adnexia, because when torsions happen and it's chronic torsion, this will lead to ovarian gangrene, autoamputation, and failure of the ovary involved. Ovarian torsion units also, it's difficult to diagnose, but occasionally associated with serious sequelae like death because they can enter septic shock and it can result in death. The size of ovarian cyst does not affect the likelihood of ovarian torsion. So ovarian torsion in neonates, it is rare, but it can occur, especially if it was diagnosed antenatally. Symptoms from ovarian cyst in neonate include vomiting, failure to survive, and due to small bowel obstruction or volvulus from bowel adhesions, respiratory distress due to mass effect, and anemia, hypovolemic shock due to hemoperitoneuria associated with cyst hemorrhage and rupture. So it have really very bad complications. It may be diagnosed as a palpable abdominal mass or incidental during image for other medical conditions. So this table will summarize the complications from fetal neonatal ovarian cyst, torsion, hemorrhage, rupture leading to peritonitis, renal compression, pulmonary hypoplasia, especially if the cyst is big, urinary tract obstruction, aortocaval shunting due to the compression, difficult delivery, respiratory distress after birth. What about the management? So antenatal, we'll divide it as antenatal and postnatal. For antenatal cysts, there is no standard care. It's only rare case that we need intervention. As we said, 54% of all cysts resolve during pregnancy with higher rate of resolution up to 80 to 90% after birth, especially if the cyst is less than 4 centimeters. Given the high rate of uterine torsion, because we mentioned that torsion can happen in utero, maybe we can consider antenatal intervention by aspiration to avoid complication. That's, we do it if the cyst is big or we are afraid about any complications. Aspiration has some complications like hemorrhage, preterm labor, premature rupture of the membranes, needle injury, infection, but usually these aspirations are done at late gestational age. The greatest risk of antenatal aspiration is the misdiagnosis. So we have to diagnose first, make sure that this is ovarian cyst, because if we do the aspiration for any other diagnosis, we can create more complications. This can recurrence after aspiration because still the hormone effect is there up to 38%. What about the neonates, which you will be called for? The risk of malignancy in fetal and neonate ovarian, we said it's very extremely low. So there's a criteria suggests expected management in asymptomatic neonate. So if it's ovarian origin, no solid component, simple looking in the ultrasound, tumor markers are negative, and we'll elaborate more in tumor markers in children, which is alpha-fetoprotein, beta-HCG, LDH, and after counseling the family. Why I put family in a red zone? Because you have to counsel the family about the expected management. Also, you have to counsel them about the follow-up, also counsel them about the outcomes. Because when you tell the patient, the family, that most probably it will resolve, but you have to educate them about the signs and symptoms of torsion, because this is an emergency. When expected management is chosen, we will follow up with serial ultrasound at the newborn period. We have to make sure that it's not complex and the size is not increasing, because this is most predictive that patient maybe need intervention. Many simple cysts will resolve by 6 months of age. Final resolution will be up to 16 months. So you can prolong the expectant management, but with careful follow-up. Surgery is only undertaken for symptoms, inability to continue follow-up, or increasing size or persistence. So up to, we said 100%, they resolve without intervention, especially if they are simple. Complexity of the ovarian cysts, like if the cysts have like symptoms or solid component, it will result in antenatal torsion or even postnatal torsion. The persistence of neonatal cysts, especially in the presence of complex elements, should raise the consideration of a rare diagnosis like ovarian neoplasm, either malignant or benign, but more in the benign size. And in these circumstances, surgical management is indicated. What about postnatal aspiration? I think it's less commonly used. Aspiration of complex cysts is controversial because in very rare cases, if the baby have a mature teratoma, aspiration can lead to, theoretically, to clinical peritonitis and pelvic adhesion. And as we said, we have to make sure about that diagnosis, because there is other causes of adnexal masses other than ovarian pathology. Surgery based on the presence of symptoms or for asymptomatic cysts that they are complex, not resolving with initial expected management, those are the indication of surgery. Always we are thinking about minimal invasive techniques should be the least aggressive surgery to preserve the maximum normal ovarian tissue. Surgically guided aspiration, fenestration, and roofing of the cyst and cystectomy is preferable than oophorectomy in simple ovarian cyst, even in the presence of torsion. The torsion of the ovary doing the cystectomy, this is the best management, unless there is autoamputation or necrotic ovarian tissue that we cannot rescue. At that time, we go for a oophorectomy, or if there is any suspicion of malignancy. For follow-up, we don't provide long-term follow-up or monitoring for patients with neonatal cyst resolve spontaneously or aspirated, because the majority are benign. For the rare patient who have non-functional cysts, we perform follow-up ultrasound and surveillance for a couple of years. Okay, that was a very quick about the fetal and neonate ovarian masses. And I think it's good to have in mind that they are mostly benign, but take care about the signs and symptoms of ovarian torsion. Now we'll talk about the bulk of this presentation, childhood ovarian masses. Adnexal masses are reported less frequently in childhood than in adolescence. Why is that? Because of lack of hormones, low levels of gonadotropins. So rarely we find functional or physiological cysts in this age. Fewer functional cysts will develop only pre-pubertal ovaries. If an ovarian mass is noticed in this age of group, we have to be reasonable and have some suspicion of neoplasia to decide what investigation and management we are going to provide. Incidence, 3 cases in 100,000 girls per year. Why it's now more common? Because the widespread use of ultrasound, ovarian cysts may currently be diagnosed more frequently, even if they are less than 1 centimeter in girls from 2 to 9 years old of age. Ovarian neoplasm, they are almost not more than 1% of all childhood tumors, but they are 8% of all malignant abdominal tumors in children. They are from ovarian origin, so they are rare, but but they present 8% of abdominal tumors. The incidence of neoplasm in this age group is higher. The incidence of neoplasm overall is higher in adolescents compared with childhood, up to 10-fold. But the type of the neoplasm, there's sometimes are more in childhood. Proportion of malignancies in neoplasm is higher in the first decade of life compared with the second, with the peak at age of 6. So overall, neoplasm, benign and malignant, are higher in adolescence, but malignancies are higher in childhood, especially peaks at 6 years old. This diagram will show you. So let's see the benign, which is the green one. So we see that the benign is, and this is the age, so 80% here, then it's down at age of 6, then it gets higher in the adolescence. Okay, the borderline is low all the time with peak at 20 years old. But see the malignant, it's low in the neonates, then it's increased here at age of 6. That's what we mean earlier. That's what we meant earlier about that in adolescent there is more neoplasm but more malignant in child. How does they present? Ovarian mass in children may present as abdominal pain, mass effects, or endocrine disturbance, because some of those tumors or masses have endocrine function. Young girls, they have long infundibulopelvic ligament and a small underlying pony pelvis. This may result in symptoms of ovarian pathology, may mimic the abdominal rather than pelvic. So that's why the young girl, she will not present with like pelvic pain because they have small pony pelvis, they have long IP ligament. So the ovaries, all the symptoms will be abdominal. Pain is the most common presenting symptoms. So pain presents up to 70% of the cases. Acute pain results from cyst complications like hemorrhage, rupture, torsion. Most common misdiagnosis of childhood ovarian masses is appendicitis. So mainly when a girl comes with abdominal pain, thinking is about appendicitis, but when they take care of surgery, it appears to be ovarian mass. Palpation of the mass is less frequent. Patient can present with vomiting, fever, anorexia, constipation, weight loss, abdominal distension, urinary symptoms. Also, they can present with endocrine manifestation like precocious puberty, virilization, vaginal bleeding, mainly with 6-cord stromal tumors, and we'll discuss this later. Follicular cysts and germ cell tumors have all been reported as associated with hormonal function and production, but mainly we are concerned about the 6-cord stromal tumors if there is signs of precocious puberty, virilization, or vaginal bleeding. So what's the etiology? So etiology could be functional cysts, but as we said, it's very less common. Benign and malignant ovarian neoplasm, paratubal para-ovarian cysts and Mullerian anomalies, and of course, non-gynecological pathology. So let's see this picture. This shows the layers of cells that represent what kind of tumors can we have. So from the 6-cord stroma, we can have granulosa cells, sarcoma, fibroma, sertuloliding, sertuli, steroid, and those are called 6-cord stroma, and they usually present as solid masses, and they are early diagnosed because of production of hormones. So there will be signs and symptoms. From the germ cell layer, there will be dysgerminoma, yolk sac, embryonal carcinoma, choriocarcinoma, teratoma, and we'll discuss in details. Surface epithelium stroma, we can have serous, mucinous, endometrioid, clear cell, transitional cell, but those are more in adolescent and adults. This table will show the differential diagnosis, benign and malignant. So for benign, mature teratoma, cyst adenoma, fibroma. So each cell line will have the benign and the malignant. Non-neoplastic will be the functional cyst and paratubal para-ovarian, but those are less commonly in children. Malignant, as we mentioned before, it could be from any cell type. So from the epithelium, we'll have the serous and mucinous, endometrioid, clear cell, borderline, germ cell, we have the gonadoblastoma, dysgerminoma, choriocarcinoma. 6-cord stromal cell will have, as we said, granulosa, theca cells, sertuloliding, and gonadoblastoma. And also, we don't forget about metastatic, especially lymphoma. So this is very important. In the child age range, the most common origin for ovarian neoplasm is the germ cell line, accounting for approximately 70% of the tumors. And when we say 70, it's either the benign and the malignant, okay? So let's talk about the germ cell tumor. So we have the teratomas. Teratomas can be benign and can be malignant. The mature ones, which we call dermoid cysts, are the most common. Immature teratomas are less common, and they are malignant. Dysgerminoma, these are the female version of male seminomas and are essentially comprised, they are mainly immature germ cells. And I think you had earlier presentation about germ cells tumor. Yolk sac tumor, these are carcinomas, epithelial neoplasm. Mixed germ cell tumors, they can be combination of teratoma with yolk sac, dysgerminoma, or embryonal carcinoma. And there is rare ovarian germ cell tumors, which is pure embryonal carcinoma, non-gestational choriocarcinomas, and pure polyembryoma. So this diagram will show us that at the age from 2 to in the childhood to 10, you can see the germ cell tumor is the most common neoplasm of the ovary. Others are less. We can see that sixth cord is the second. Then epithelial are very less than that. Okay, others we mean metastatic. Both epithelial and stromal tumors are uncommon in the first decade of life. However, stromal tumors account for a large proportion of surgical masses between age 2 to 6 years old. The most common ovarian neoplasm in children is mature cystic teratoma. The most common ovarian neoplasm in children is mature cystic teratoma, which is from the germ cell tumors. The malignant germ cell tumor consists of dysgerminoma, endodermal sinus, immature teratoma, and embryonal carcinomas, as we mentioned earlier. How to evaluate children with ovarian masses? So careful history and physical examination is the key for that. Height, weight, general appearance, abdominal examination. We can also inspect the skin. Maybe we can see caveolate spots, which can come with McCone-Alpert syndrome, which are associated with ovarian masses. Thyroid nodule may be related to hypothyroidism. Evaluation for sign of hormonal production with sexual maturity. So you have to examine the breasts, the pubic, the axilla, to see any signs of premature puberty, precursor puberty. Look for isosexual precursor puberty and fertilization and hirsutism, clitoromegaly, change in the voice, abnormal hair distribution. And as I said, external genitalia is very important. You can see signs of externalization of the hymen. Hymen will be so pink, or sign of virilization like clitoromegaly or abnormal pubic hair. These are like a picture for caveolate spot. Then after that, you will go for imaging. The gold standard, and not the gold standard, the initial modality is ultrasound. And the ultrasound, what you are looking for, the size, the characteristic, the thickness, the mural nodules, any septation, any bilaterality, any pelvic fluid, ascites, hemobrytonium, and the appearance of the uterus. Always look for, if you are looking for something like in the right side, look for the left side, look for the ovary, evaluate the pelvic. Also, ultrasound Doppler is important sometimes, especially in case that you are suspecting patient coming as emergency with abdominal pain, and you found that there is adnexal mass. You check for Doppler to see if there is or not. If the ultrasound is not satisfactory, we can go for CT and MRI, especially if there is like suspicion of cancer or complication. We prefer MRI in children because the absence of radiation, and all we needed to see the origin, or if the ultrasound is not conclusive. Also, we can look for presence of any lymphadenopathy or extra ovarian disease in case of suspicion of malignancy. Then one important thing in the investigations in this age group is the tumor markers. As we said, because most of the masses in this age are not functional cysts or physiological cysts, and some of them they produce some tumor markers that help us or guide us to reach diagnosis. Tumor markers should include alpha-fetoprotein, LDH, and beta-HCG if malignancy is suspected. These tumor markers are positive in multi-potential germ cell tumors. So mainly we are looking for germ cell tumors. Mature or immature teratoma that contain malignant elements may secrete alpha-fetoprotein. LDH are mainly positive in dysgerminomas, but they are not specific. CA125, it is positive mainly for epithelial tumors, but it's not specific because it can be indicator for any peritoneal inflammation or GI maybe malignancies. So it has limited value in this age group. If the examination suggests hormonal production by the tumor, you can ask for serum estrogen, androgen level to confirm your suspicions. Granulosa cell tumor, which is a 6-core tumor, are indicated by an elevation in inhibin level, but this is not routinely available in the hospitals. Sorry, these tables are not very obvious, but I think we can see that this table will show us the tumor markers and in which tumors it will be elevated. We are talking about the germ cells. So we can see that alpha-fetoprotein is elevated in endodermal sinus tumor, embryonal carcinoma, and maybe it elevates in mature teratoma. LDH is mainly elevated in distal melanoma. Beta HCG is elevated mainly in embryonal carcinoma or choriocarcinoma, sometimes with distal melanoma. This is the same table. When we talk about the management, we have the management of ovarian cysts in children is related to the symptoms and the concern of malignancy. Expect management with conservative follow-up for non-concerning ovarian lesions is feasible in children and should be the method of choice in selected cases for simple ovarian cysts. Expect management is possible in up to 80% of masses referred to us in gynecology. But we have to decide a set of criteria and risk for malignancy. So the criteria for deciding for surgical management, persistent or non-resolving symptoms, suspicion of torsion, sign as symptoms of large mass associated with complication like hydronephrosis, any concern for neoplasm, or unclear origin of mass. And also we have to put risk stratification. There are several algorithms was developed to see, to guide when we go for surgery, when there is high suspicion of malignancy. But in general, with a good history and physical examination and imaging features, the age of the patient and tumor markers, you can see if the patient's high suspicious for malignancy or not. And at childhood, the proportion of masses representing malignancy is high. That's why you have to do all the work up before deciding going for conservative management. It's the opposite in the antenatal and neonatal masses. So factors associated with higher likelihood of malignancy: if the patient is young, if having precocious puberty, virilization, abdominal bloating, history of ovarian malignancy in the past, if the tumor markers are elevated, or the imaging characteristics are more towards the malignancy. This is a simple flow chart for cyst diagnosis in ultrasound. So if the patient, if this is diagnosed in ultrasound, we'll see if the patient is symptomatic, if not symptomatic. If the patient is symptomatic, you have to think about torsion, either with pathology or without pathology, because it can happen even with if torsion can happen even with normal ovaries. So if the patient have abdominal pain, keep especially young girls, keep the suspicion of torsion. If the patient is not symptomatic, we see in the ultrasound if the cyst is simple or complex. If it's simple, what is the size? If it's less than 5 centimeters, we follow up. We educate the patient about the signs and symptoms of torsion. If 5 to 7 centimeters, we also follow her up. But if less than 5 centimeters, no need for follow-up if it's simple. If 5 to 7 centimeters, we follow them up and maybe we refer them to gynae clinic. If it's more than 7 centimeters and there is some suspicion in the ultrasound, or you are not sure about your ultrasound, you do the tumor markers and do more maybe investigations. If it's complex from the beginning, you do your tumor markers and maybe plan for surgery. The principle of surgical management, it's always the same toward ovarian preservation and minimizing the adhesions and preserving fertility and the hormonal function. If there is a low index of suspicion of malignancy, laparoscopic approach with ovarian cystectomy is the procedure of choice. But sometimes, even with ovarian masses, sometimes it's too big to approach laparoscopically. So maybe mini laparotomy is indicated in those cases. With mini laparotomy, we can do decompression of the cyst. Then after that, we do cystectomy. Cystectomy is the best for benign lesions and also for mature cystic teratomas. Let's talk about the most common ovarian neoplasm in this age group, which is mature cystic teratomas. How can we differentiate? There is some ultrasound characteristics. Rokitansky nodules, These are dense tubercle in the cyst lumen, which will have shadowing from its chronicity in the ultrasound. It's very characteristic. There is dot dash sign arising from the presence of hair in different orientation. Also, in the ultrasound report, you will see that intramural fat fluid level, some calcifications. These are reassuring that this is mature teratoma or dermoid cyst. Why these signs we see it in the ultrasound? Because this reflects the presence of various tissue types from the 3 germ cell layer: ectoderm, mesoderm, and endoderm, which most commonly after surgery we see that it is hair, bone, and teeth. Surgical approach for mature cystic teratomas, controversial. There is a theoretical risk about rupture and intraoperative spill, which can cause chemical peritonitis. But ovarian cystectomy by laparoscopy, it have higher rate of spillage, but this does not mean that we go for laparoscopy. Sometimes it is easy. Even if there is some spillage, we can do good washing, and sometimes we cover them with empiric antibiotic and it is okay. But we go for the minimal invasive way and we do cystectomy. So this is open mature cystic teratoma, and I'm sure like most of you saw one, and you will see that there is a spacious material, whitish greenish yellowish greenish material. You can see some teeth, bone, and this ball of hair. Post-operative pelvic ultrasound should be considered to assess for teratoma recurrence because they can recur. The recurrence is more when the dermoids are large or bilateral and multiple. They can occur as bilateral in 10% of the cases. That's why conservative management is even more important, because if you open patient and you find that you have bilateral, you cannot remove both ovaries. And also with this recurrence, if the patient, if you ignore doing cystectomy and you proceed with oophorectomy and the patients present again with dermoid cyst in the other sides, this will affect the patient fertility and hormonal production. Okay, so when we were dealing with benign masses, we were talking about cystectomy. What about when we are talking about malignant? At this stage, we need surgical staging. It is done for malignant ovarian neoplasm. Why? To make the decision for post-operative any adjuvant chemo or radiation. Pediatric germ cell tumor are staged using the system developed by Pediatric Oncology Group. We'll see this after a while. If a germ cell tumor is suspected, the primary tumor is resected with unilateral salpingo-oophorectomy without interruption of the ovarian capsule on the surgical field, because this will upgrade the stage. So if you are like all the investigations and the looking of the tumor is malignant, you do unilateral salpingo-oophorectomy. Intraoperative staging include collective of ascites, peritoneal washing for cytology, inspection palpation of peritoneal cervix, contralateral ovary, pelvic and para-aortic lymph nodes bilaterally, and omentum with biopsy only if abnormality. So if you inspect the omentum and there is any abnormality, anything abnormal or suspicious, please biopsy it. Extensive germ cell tumor should be biopsied for diagnosis, but aggressive surgical procedures are not undertaken at the risk of harm of a vital structure. What that means that if you open the abdomen and you saw that the germ cell tumor is very aggressive, take biopsy, do what can you do, like remove what you can remove, but without affecting other structures, because those are very sensitive and they respond to chemotherapy. Post-operative chemotherapy for germ cell tumor include bleomycin, etoposide, and cisplatin, has resulted in marked advance in survival compared with previous regimens. So this is the regimen of choice. Okay, those 3 tables are very important and they summarize whatever I said. So these are the COG surgical guidelines for ovarian mixed germ cell tumor guideline. So this is the surgical staging. Here, as we mentioned, the stage 1 is limited to the ovary and everything else is negative, and tumor markers normal after appropriate half-life, like after surgery. Stage 2, microscopic, there is microscopic involvement for the lymph node. Stage 3 involve omentum, intestine, or bladder, and lymph node is more than 2 centimeters. Stage 4 is distant metastasis, including the liver. So what is the treatment? So if you see here in the ovarian, if it's low risk, that means no extra, so if it's only in the ovary, here from stage, if it's only in the ovary and no extra ovarian involvement, surgery alone is enough. Intermediate risk, stage 1 to 3. If there is any positive or if the tumor markers are not normalized, maybe we can consider 3 cycles of PEEP after the surgery. Stage 4, we do surgery and we do 4 cycles of chemotherapy, and we follow up with the tumor markers. 6-year survival rates up to 98% reported for malignant ovarian germ cell tumors after 4 cycles of PEEP, with good staging and post-operative monitoring to determine the need of chemotherapy. 60% of stage 1 germ cell tumors can now be managed without any need of chemotherapy with good staging. Ovarian function, we cannot say that it's evidenced by ongoing menstruation, but also by pregnancy. So we cannot say that if the patient gets period after, like she gets her period later, 2 to 3 years after that, or after the surgery, we cannot say that this is like the ovarian function are reserved until like she gets pregnant, or sometimes you can measure the ovarian reserve. There is a pregnancy documented with even those cycles of chemotherapy, because the chemotherapy type that's used is less toxic for the ovary. For epithelial cell tumors are staged according to the FIGO system, which is the same in adults. And as we said, epithelial cells tumor is less common in childhood. Epithelial cyst adenocarcinoma are extremely rare in childhood. Management, it's as per adult guidelines. So mainly they are referred to gynecologists. Low malignant or borderline tumors are managed in young patients with unilateral salpingo-oophorectomy, but this mainly in adolescents rather than the children. It's managed by unilateral salpingo-oophorectomy, a mental biopsy, and resection of all visible disease. So it's like debulking. If the epithelial tumor is mucinous, appendectomy is recommended because we have to rule out synchronous gastrointestinal lesion. For the 6-cord stromal cells, these tumors often present as early stage. Why is that? And this can come as MCQs or OSCE. These tumors present in the ultrasound as solid tumors, solid adnexal mass, and there is clinical symptoms or signs. So the patients can present with precocious puberty, can present with abnormal breast enlargement, precocious thelarchy. They can present with virilization symptoms, because as we said before, 6-cord stromal cells are mainly hormonal production, and they are rarely requiring post-operative chemotherapy. This is for the children, and mainly when we talk about the children, we talked about germ cell tumors. Let's talk in like summary about the adolescent ovarian masses, because most of those are managed by gyneco-oncologists, but I think sometimes still the definition of pediatrics and adolescent differ from one hospital to another. I know some hospitals, they don't see adolescent, they consider adolescent after age of 14. Some of them, they consider it after that. So ovarian cysts overall are more commonly in adolescents compared with children all over. Management style in this age group must reflect toward formation of functional cysts and post-menarche. So why we have more cysts in this age? Because already the hormone levels rise again, and any hormonal imbalance or anything, they can present with cysts. So mainly in this age group, we deal mainly with the complications of the cysts, even if it's physiological or functional. So functional ovarian cysts often result from failure of maturation of follicle to ovulate and to ovulate, and represent up to 50% of adolescent ovarian cysts. And ovulate and represent up to 50% of adolescent ovarian cysts. Often, these cysts are simple on ultrasound and they are self-limiting with time. Functional cysts may also reflect the persistence of corpus luteum. So it's only all are part of physiological pattern. Approximately 2/3 to 3/4 of functional cysts will regress within 2 to 3 menstrual cycles. So that's the first management when I scan a patient and I see that she have 4 or 3 to 4 or even more simple cysts. I give her follow-up after 12 weeks with the scan, and most of the patient it will regress. Functional cysts can complicate by hemorrhage, and hemorrhage can present with acute abdomen. The average diameter of hemorrhagic cyst is like from 3 to 3.5 centimeter, but they can be up to 8.5 centimeter in ultrasound. They can present, as I said, acute abdominal or pelvic pain mid-cycle or in the luteal phase with fever and leukocytosis, without any fever or leukocytosis, except if there is irritation of the peritoneum. If the cyst will rupture, hemoperitoneum will develop, and patient may develop peritoneal signs in examination and maybe have hypotension. Differential diagnosis in this age group, we have to raise a suspicion of also an ectopic pregnancy, an inflammatory process like tube ovarian abscess, because in this age they become sexually active. Also, we have to keep in mind ovarian neoplasm. Although they present, hemorrhagic cysts can present with pain in presentation, but they gradually resolve without any intervention, especially if the patient is hemodynamically stable. No need for any intervention, and they only require analgesia. As we said, differential diagnoses also include benign and malignant ovarian neoplasm. We have to think about endometriosis in this age group. Regarding the ovarian neoplasm, malignancy in adolescents range from 2 to 10%, incidence decreasing with age. Low malignant potential tumors begin to appear in early adolescence. So if you remember the diagram I showed earlier, we saw that the malignancy is highest in childhood, then it decreases in adolescent, but the borderline and the benign increase in adolescents. Tumors may present in adolescent ovary. Germ cell still is the predominant, with mature teratoma or dermoid cyst is the most common neoplasm. We have to think about any disorders of fallopian tube like hydrosalpinx, paratubal cyst, hematosalpinx in case of endometriosis. Also, we have to keep in mind ectopic pregnancy, and also we don't forget about non-gynecological etiologies. Management always start with a full history and examination, but for this age, we have to take full menstrual and sexual history, in addition to the history of presenting illness. Investigations should include beta-HCG if the girl is sexually active. Speculum examination if the patient is sexually active is important, with taking all the needed swabs like chlamydia and gonorrhea. If we are suspecting tube ovarian abscess. Ultrasound, as the other age groups, is the initial imaging of choice. And the most important thing, we have to be more towards the conservative management unless there is a complication. If we lean towards the conservative management, we have to give instruction both to the patient and the family we have to educate them about the symptoms of adnexal torsion, because this is an emergency. As we said before, hemorrhagic cyst, although we can manage it conservatively, but if there is frank hemoperitoneum, we have to clean it by surgical management. Indication for surgery should be considered if there is no regression for 2 or 3 menstrual cycle, or there is increase in size, any suspicion of malignancy, or if there is any acute symptom like acute abdomen or that represents maybe torsion. Ovarian cystectomy again should be performed unless there is a high index of malignancy, and the index of malignancy is the same as in the children. So I didn't go in details in the adolescents, because I know mainly you are dealing with children, but these are some of the things that you should know and manage. The last thing I want before taking your questions, I can see there is some questions. I'll answer them one by one. But let's talk about fertility preservation in pediatric and adolescent care. I'm not sure if this is going to help you in the exam, but I'm sure this is going to help you in your life. practical life. Also, it will help the girls that you are taking care of, because as I said, you are the first to see this age group, and they trust you more if you refer them, like if you give them the idea about fertility preservation, even if you are not doing it. But if you as the primary doctor, if you give them the idea and then refer them, they will trust you more. So American Society of Clinical for Clinical Oncology have published guidelines recommending fertility preservation, counseling, and care prior to cancer treatment. Let's talk about oogenesis and ovarian reserve. Maximum oocyte number is achieved in utero, approximately up to 7 million oocytes at 20 weeks of age. Okay, so the girl and her mother, when her mother is pregnant with her, she have like 7 million when she's 20 weeks, and this is like huge. But unfortunately, with the atresia and degeneration, this decreased to 500 to 2 million at childbirth. Also, atresia and degeneration continue, and maybe it reached 500,000 at the time of puberty, and less than 1,000 at menopause. And every cycle, there is the oocytes are depleted, and there is some atresia. The ovary is not. When we talk about fertility preservation, it's not only for future having kids in the future. It's also for production of sex hormones. Sex hormones are very important for all the aspects: bone, heart, cognitive function, skin. So when we talk about preservation, we also aim for these things. Gonadotoxin therapies or surgical removal of the gonads can have lifelong effects on both fertility and overall health. Fertility can be affected by surgical removal of reproductive organs, chemotherapy, or radiation. So what we need from you, or what is the concept that I want you to know. When you see the patient and you diagnose her, and this is for the ovarian tumors or any tumors, any cancer in pediatrics. When you have the diagnosis and you develop a treatment plan, assess fertility risk. See if the patient have her period, didn't have her period. Discuss the impact of treatment on reproductive health with the patient if she can understand, and also the parents. Always involve the patient. Even if they don't understand, they feel more comfortable involving. If the patient is interested in fertility preservation, refer to a reproductive specialist, discuss fertility preservation option. If they maybe after discussion they want to proceed or not, it's up to them. If the patient refuses that, make sure that the family and the patient get the whole idea, because during the when the patient is coming with a cancer and you are talking about surgery to cure the cancer, maybe the patient and her family are occupied by the present illness. They are not thinking about the future, but because we know with high advanced medicine, surgery, chemotherapy, radiation, the survival rates are more. So the regression rates will be more. What are the options? For radiations, strategies for fertility preservation in both males and females. Radiation therapy for pelvic organs or gonads, shielding, using of shielding to reduce the damage. Ovarian transposition in females is very it's very simple option. It's a day surgery option, and it can be very safe and protective. Fertility sparing oncology surgery, as we said, if we can go only with unilateral salpingo-oophorectomy, avoid doing unnecessary hysterectomies, this is very good approach. And high risk, if we are using chemotherapy or there is a very high risk of gonadal damage, freezing of embryos. Mainly we use it in adult, but freezing of oocyte and gonadal tissue freezing is an option. So this diagram is 2013. Since then, there is very huge change in this area. In some hospitals now, they offer the oocyte for females, and gonadal tissues will be available in the coming years. Even if it's not available in the public hospitals, give give the patient the options. Tell them they can know that there is either inside the kingdom there is some centers do the oocyte freezing. There is outside this is oocyte freezing for females who already have their periods. For females they didn't have their periods. For young girls, gonadal tissue freezing, ovarian tissue freezing is an option. Maybe it's not available here in the kingdom, but always give the patient the option. So for girls, pre-pubertal, ovarian tissue banking, post-pubertal, if they are willing for ovarian stimulation, because oocyte freezing include ovarian stimulation. If they are okay with that, we can do oocyte banking. During cancer treatment, we can do ovarian transposition and radiation shading. Also, we can give GnRH agonist. So we can shut the ovarian down, because we know that the chemotherapy and radiation target the most active tissues. So if we give GnRH agonist and we suppress the ovary, maybe there is a theoretical proposal that we are protecting the ovary. This is what I have for ovarian preservation. I'll start with the questions. The first question, yes.
Yeah, so thank you, Dr. Hanan, really for your nice illustration and thorough review. And I encourage the audience to drop their questions in the question and answer. I think we have some of it. I think Dr. Hanan will go by.
Yes, I'll go by one. Yes. The first question is any role of hormonal therapy for ovarian cysts? So hormonal therapy, I think you mean by combined contraception or combined contraception mainly. Yes, there is a role, but it works in preventing recurrence of the cyst rather than diminishing the current one. The second question, why all the appendectomy in mucinous epithelial tumor if there is associated GI cancer risk? So if you go through the mucinous cell tumor, the histopathology can come to, there is two histopathology. It's either GI or endocervical. So during the OR, sometimes you don't know if it's always we encourage inspecting the appendix during the surgery if we face mucinous cancer, because it could be origin from the appendix. Some literature suggests that we do appendectomy regardless. Other literature, they suggest inspecting. Sometimes you see mucin or any signs on the or abnormality in the appendix. At that time, you can remove it. So yeah, I think Abdullah asked, if patient came to ER with torsion and laparoscopy you found an ovarian cyst, what is your approach for such case? Okay, so if the patient comes to the emergency with a torsion, laparoscopy, what you will do first, detorsion. Okay, then if everything is okay after detorsion, you do cystectomy. There is some doctors, they prefer to do it 2 times, especially if the cyst is big and there is very fragile tissue. They do it after 6 weeks after the first surgery. But for me, we do it in the same set, detortion, and we do ovarian cystectomy.
Dr. Hanan, let's make it a bit complicated. If this cyst is complex or there is a mass during the laparoscopic exploration for torsion.
Right. If there is a mass, you do cystectomy, and if there is, as we said, if it's the most common is mature teratoma, صح? Yes. We said mature teratoma, it will be very obvious that it's mature teratoma. If it's not obvious and you did the cystectomy, you can send it for frozen section. But if there is signs of extra ovarian involvement or you see very ugly mass, at that time you can proceed with oophorectomy because of high suspicion of malignancy.
Mm-hmm. What about the option to just derotate and close the patient and ask for further radiological investigation and I mean after biopsy and the tumor marker, and then to go for another?
This is also an approach, but as we said, if we can detort and do the cystectomy, usually with inspection, it could be like mature teratoma can present as a complex. But if you see that it's a frank suspicion of malignancy, yes, if you didn't consent the parents for oophorectomy, you have to close. Mm. If you didn't consent, you have to close, and it's really a surgeon call.
Okay, thank you. So the next after that,
please tell us about post-op management of malignant cell tumor
The
should
surveillance,
be
I mean.
for how long and what investigations should be done. طيب. In the first post-op, you will do after post-op, like you will give the patient 3 months in the clinic. You will do tumor markers. This is the most important thing. This is if the patient did not require chemotherapy. So it depends on your staging. So in germ cell, we said that we do complete staging. If the staging came as stage 1 and did not require any chemotherapy, we follow up in the first year. We follow every 3 months with the tumor markers, okay? And after that, second year, it will be every 6 months, then annually for, I think, total 5 months, 5 years, sorry.
So the next after that, would you please repeat the management of bilateral mature teratoma?
Would you please repeat mature bilateral? Okay. So what I meant by when I said that mature teratoma, they can present up to 10% bilateral. That's why we usually encourage cystectomy. So if you open and you find bilateral, remove bilateral cystectomy. Never, like if it's really not indicated or gangrenous or amputated ovary, please don't do oophorectomy, because they tend to recurrence and they tend to be bilateral. That's what I meant by if you find mature teratoma bilaterally, remove both bilateral cystectomy, but really reserve the oophorectomy for really complicated cases. So Dr. Asiri asked, do you ligate the fallopian tubes with ovarian transposition? Actually, Dr. Ali, we don't, but sometimes if the tubes are not moving with us, sometimes we do salpingectomy if the fallopian tube is if the ovary is not mobilizing with us. But there is some literatures, they suggest doing the ligation. What do you mean by ovarian transposition? So where is the ovarian located? In the ovarian fossa and the pelvic, okay? When you are planning to do like radiation for sarcoma, I think sarcoma, yes. If you're doing any radiation for any pelvic radiation for any tumor that you are doing in pediatrics. So when what do we mean by ovarian transposition? Is moving the ovary from the field of radiation in the abdomen. Sometimes we can placate it at the side walls. Some they do it, they placate it to the abdominal wall. That's what we mean by ovarian transposition. I think
the next two questions the same.
Yes. How do fellow malignant? I think we answered also about the germ cell. And the protocol for germ cell and pediatrics, I think it differs from the adolescent, but I think it's the same. The most important thing, if the patient is stage 1 and low risk, tumor markers, and sometimes we order ultrasound because germ cells, they appear in the ultrasound. But to detect early recurrence or anything, I think tumor markers are the best to follow up. Does the large ovarian cyst increase the risk of torsion? Okay. In pediatrics, it does not, because as we said, a torsion, where does the torsion happen? It happens around the IP ligament, and we said the IP ligament in pediatrics is long. That's why we can have a torsion. But the heaviest the cyst, the more it's the less it can tort. So with immature teratoma and with complexes, less likely they present with torsion. Please elaborate for more advanced malignant lesions or bilateral lesions. Complete staging, as we mentioned, there is. I think the slides will be shared with the attendees.
Yeah, and also the lecture is recorded.
Yeah. So the staging, any suspicious lesion, you have to do the complete staging, and the complete staging it includes what we do for the advanced malignancies. But we said in the germ cell tumors, even if there is advanced malignancy, do what you can do, like remove whatever you can see from the malignancy without affecting the vital organs because it's very sensitive to chemotherapy. This is switch and teratoma. Right. Teratoma, because we said it have multiple germ cell layers. There is hair, there is bone. Sometimes we can do the cystectomy and there is no spillage. But if spillage happens, only there is a theoretical of chemical peritonitis. So if the teratoma is big and you know that it's teratoma, you can do control aspiration. What do we mean by control aspiration? That we do small incision, insert section and close around it. After that, we can suture that site and continue doing the cystectomy.
Okay, I've read that we have only five more minutes.
The role of ovarian by valving and ovarian torsion. I don't understand the question.
I think they mean by valving of the ovary itself.
To cut the ovary?
To cut it, yeah.
No, I don't. I'm not aware about that. Detorsion, and if the patient have recurrent spontaneous, I mean by spontaneous, there is no cyst. If the patient have recurrent spontaneous torsion, maybe we can do plicating, fixing, ophorepexy, yes. Ophorepexy, we can do it in recurrent spontaneous torsion, not in the one with cyst, because if the cyst, we know that the torsion happened before because of the cyst, but if the patient have recurrent spontaneous torsion, we can do ophorepexy. Indication of hysterectomy and ovarian tumor. Mainly, we do it. It is not part of the staging unless if there is a clear involvement. But usually, it is not part. Hysterectomy is not part of ovarian staging in any age. It was believed that it's part of, but it is not. I think those are all the questions. No,
yes.
Fixation was done. I think we covered all.
Yeah, I saw one question in the chat that about the doing full investigation for neonatal ovarian cysts like LDH, alpha fetoprotein, and beta H. Is it mandatory or just?
No, we did in the neonate. It is mainly if the ultrasound showed simple, no need, because mainly it's due to hormonal withdrawal and the maternal effect of the hormonal. But if there is any complexity, any solid component, at that time you can do the tumor markers.
Okay, Dr. Hanan Alshankiti, thank you for answering our invitation, and thank you for this really great and wonderful illustration and review. كلمة أخيرة لك أو حاجة حابة تضيفيها؟
Thank you for inviting me. I hope all the best for you. I hope that I tried to cover it from pediatric surgeon point of view. I hope that I covered well. I'm open for any question. I think I shared my email with the organizing committee. Any questions or anything, I open for that.
Thank you, Dr. Hanan, and I encourage the audience to drop their question either through our Twitter or then later on we'll provide Dr. Hanan email if she doesn't mind. And okay,